Howdy, everyone. Welcome back to episode 5 of 584 Vetoes, the podcast that no one pays for, leading to poor incentives to all the listeners. Today, we're trying to figure out why we don't have more physicians in America, and we'll also answer some listener feedback about curbing or subsidizing drug innovation. I'm Tom Church.
I'm Danny Heil.
Today, we're actually talking with Lawson Mansell, a health policy analyst at the Niskanen Center, and more importantly to Danny and me, a fellow graduate of Pepperdine's School of Public Policy. Lawson, how are you doing today?
I'm great. Thanks for having me on, guys.
This is like I think you said, the first time 3 public policy graduates from Pepperdine are all in the same virtual room together doing a podcast. I think that's pretty good.
Yeah, that's great.
So Lawson, today we're talking to you about your excellent report, which you titled Healthcare Abundance, an Agenda to Strengthen Healthcare Supply. And we want to focus on one special part, but listen, I really enjoyed reading it. Will you give us a quick overview? What do you cover in the report, diagnoses and solutions?
Yeah, so I think stepping back a little bit, one of the things that I think many of those in the healthcare space notice is just sort of a dearth of folks talking about healthcare from the supply side perspective. And so I think one of the major goals of putting out this report is to start conversations, to socialize the ideas around some of the issues in healthcare stemming from a lack of both enough doctors to provide care to patients and also a lack of actually facilities where folks can receive that care, which I think is probably under-discussed as well. But in addition to that, I think there's been critiques from folks on both sides about this sort of supply side perspective, arguing that, well, one, there's overutilization of care that drives our high costs. And so, the report's idea is to sort of get at what are those supply side reforms that need to be done, whether that's deregulation or increased funding, but then also what are the market mechanisms that actually prevent supply side reforms from working? So what about hospital consolidation? What has been driving consolidation? How does that affect the prices of healthcare and rising costs? And so the report kind of takes those two buckets, both hospital consolidation and those market incentives, and also just the straight supply restrictions on healthcare, to say that if we can do both things, if we can improve competition by reducing consolidation in the marketplace, removing those perverse incentives hospitals have to consolidate, and also improve competition by reducing supply restrictions, those things work together and will benefit patients. And so the report looks at the history of some of these supply restrictions, the history of these perverse incentives, and provides sort of a path forward for what abundance, increasing access, increasing supply of healthcare services looks like.
So I like the notion of looking at the supply side because it is one way to drive down prices, increase supply. Before we talk about why there aren't more doctors in America, why we've got this shortage, according to, well, often the Association of American Medical Colleges. So Danny's already skeptical, but we'll go from there. On the consolidation issue, really quickly, why is it that we don't have more physician-owned hospitals?
Yeah, so the at the moment, I think the crux of the reason why we haven't been able to create more physician-owned hospitals was actually the Affordable Care Act. When the Affordable Care Act passed, they essentially grandfathered in the existing physician-owned hospitals, but prevented future physician-owned hospitals from being created and from existing ones to expand. And so as a result, we have less physician-owned hospitals than we would have if that provision wasn't included in the ACA. We still have a lot of physician-owned hospitals. So as a result, we have good data on comparing outcomes between physician-owned hospitals and other kinds of hospitals that can inform, what we think of physician-owned hospitals, what patients think of them. And so we know that physician-owned hospitals report either similar or higher quality than other hospitals. But that restriction is still in place. And there's been, I know Senator Langford puts a bill up every 2 years.
Every year, yeah.
To try to change that. And that's something that's included in our report. We think that that's one way to improve competition in the provider marketplace.
I've heard back to physician-owned hospitals that, like, the noble thing is, well, we're worried about doctors doing kickbacks and sending all their patients to the hospitals they have a financial stake in. And then I've also heard that it was literally just a giveaway to the American Hospital Association to get them on board with the ACA. So have you heard something different? Is there a
No,
noble reason for this, or is it really
I've heard
just
the
political
same
politics?
things. I've heard less and less the conflict of interest argument, and I think
Hmm.
it's because it really doesn't make much sense. You inherent to healthcare, all healthcare delivery is constant conflicts of interest between doctors, hospitals. How many services you provide determines how much money you make. Attempting to remove conflicts of interest in healthcare is a sort of non-starter, I think, as a position. Because you're not going to be able to. Obviously, I think there are maybe more egregious examples. You can see sort of antitrust examples with the horizontal integration of some of these companies, where you have insurers owning hospitals and vice versa. And I think those are conversations worth having. But the doctor to ownership relationship is much more complicated, and you're going to have those conflicts of interest regardless of who owns the hospital.
Yeah, I always like to get the rules of thumb or the a philosophy of these approaches, and the argument is like Danny said, oh, physicians might have an incentive to raise these costs. It's kind of like an income and substitution effect here of, well, one, we can test whether that's true or not, but two, if there's more and more supply, will that just offset maybe perhaps the desire to get higher prices there? All right, so consolidation. We're really here to talk about physicians. The Like I said, the Association of American Medical Colleges says we'll have a physician shortage of 86,000 to 100,000 in 10 years. I think there's roughly about 1 million physicians in the United States or so. So you can get a perspective of the relative size of the shortage. And I think it's astonishing to really dive in here of why it is that we're not just churning out more and more physicians a year when the cost of medical care is so expensive. And one way to, so you're talking about a supply side agenda of abundance. Let's just get more and more doctors. So what's standing in the way? How does the system work right now?
Yeah, that's a good question. So I think a good way to think about healthcare, often folks do not think about it from a supply and demand perspective. And I think that makes sense because healthcare doesn't work like other services. I think making sort of comparisons to healthcare like you would buying something in a grocery store isn't entirely helpful because it's not like that at all. And I think similarly on the demand side, it's different in the sense that you're going to have a constant demand for care. But as population increases, demand for care increases. As coverage increases, demand for care increases. And so since Medicare was created in 1965, you've had a consistent increase in demand for care. But along that same line, we've been purposefully decreasing the supply of healthcare during those years. So there's a lot of things you can get into here, but I think it's most helpful to talk about residency programs. And that's because in order to become a doctor, you need to go through a residency program. We will only create as many doctors every year as there are residency slots for doctors to go in. And so you will hear often folks talk about us having a cap on the amount of doctors we can produce. That's not true. We don't cap the amount of doctors we can produce, but residency programs are subsidized. Hospitals will often argue, teaching hospitals will often argue that they do not have incentives to create residency slots where doctors can begin providing care straight out of medical school. And some of this makes sense. One, residencies are both a benefit and a cost to these programs because residents, while they will make less money than a doctor will post-residency, they often will require oversight. They'll require some training. And so there is some cost to that. They also will obviously get paid a salary. And so back in, I think we have to go all the way back
Well,
to.
and the insurance companies will, or the hospitals will bill for those residents because they're
Exactly.
still doctors at that
They're
point in
still
time. I
doctors.
mean,
Yeah, that's a fair point.
anything that
Yeah.
they're prescribing or covering will be billed and paid for.
Yeah, it's helpful to think of it as sort of like a fellowship. It's a required fellowship that the MD students must go through.
Back up for a second. If you want to become a doctor, you go to college and then you go to med school for 4 years. And there's this discussion actually out there of like, should we get rid of the fourth year? Nothing's really going on there so much. We'll talk about that later as
Yeah,
a
fair
possible
discussion.
solution. Yeah, and then from there, you graduate, you're a doctor, but you need to get a residency slot for at least 3 years?
Yeah, if you want to become licensed, you need to get a residency slot, and so those residencies, depending on what you're doing, your specialty, that'll change. You could be in residency or a fellowship program to up to 9 years. So in the U.S., to become a doctor, you have 4 years of undergrad, you have 4 years, maybe even more, post-secondary, and then you have 3 to 9 years of residency and fellowship. It's helpful because you could say, "Oh, that seems like a long time," but we don't really have comparison points. But we do in Europe. In Europe, it takes 6 years from start to finish to become a doctor, regardless of the specialty. So it's a lot harder to become a doctor in the United States than in other countries. And I think for those in the medical community, that might be something to brag about, in the sense that, well, you want high quality doctors, you want high levels of training. But obviously, in terms of outcomes, patient outcomes, the U.S. is far behind European peers on any measure of treatable illnesses, preventable illnesses, life expectancy. So we're not necessarily getting value for the amount of years that doctors are being trained. Now, that process has changed over the years. So I think it's helpful. You have to really go back to what I'd say that between 1970 and 1990, a whole lot of changes took place in the way doctors are created, the way residency programs work. Prior to 1960 or 1970, I would say, at Niskanen, we kind of call that the abundance period. You had a lot of doctors being created, and you had the opposite of the dynamic we have now with residents, prospective residents, and residency programs. You had a lot of slots. I think if you go back to 1970, it's about 10,000 slots and 5,000 applicants. So the programs themselves were competing for residents. And as a result of that, that's when Medicare started stepping in and started to subsidize these programs, because the residents had leverage. They were demanding higher salaries. They're saying, "Oh, you want me to go to your program? Well, give me a higher salary." And as a result, Medicare started stepping in, using direct payments to hospitals. But I think one of the critical flaws that happened here was the way they paid those programs for residents was actually reimbursed through the system. So you got the amount of money that you had. There's two different ways. One was there's direct payments, which cover the salary, and then there's boosted payments called indirect medical education payments, and those payments cover sort of the other costs of having these residents, and they're a reimbursement on the bed to resident ratio. So essentially, the more care residents provided, the more payments they got, and the more expensive that care was, the more payments they got.
So it's a labor theory of value.
Yeah. So as a result, over the years, we're paying at the most recent number, CMS is paying $180,000 for one residency slot at a hospital.
I did some back of the envelope or math, and that's actually the estimate that I came up with. I'm glad to know that that's what we're getting.
Yeah, that's what we're getting. And that's as of 20. That's in the COVID, somewhat post-inflationary period. Previous to that, it was about 150. Some was 100,000. If you include Medicaid payments and CMS payments, it's about 150 prior. And that's more than the resident salary is over the course of the year. So even the direct medical payment is going to cover more than the salary, likely, than the indirect medical payment on top of that.
So you've linked something in my brain a little bit, because what you said was, back in the day, we had more residency slots than we did have doctors. And so the government said, okay, well, we need more doctors, let's subsidize it. But then what happens is we spend enough money, you get more and more doctors, the numbers might start to equalize. And then what happens in 1981? Tell me about GEMINAC, the Graduate Medical Education National Advisory Committee. We're going to call it GEMINAC because it's a neat acronym.
Yeah, GEMINAC sounds good. So they essentially produced a report that argued that we were approaching a physician surplus. Now,
oh no,
yeah, too many doctors. Oh, what are we going to do? And those concerns were grounded in this idea that we were producing doctors at relatively high rates. Now, I think a couple of things they didn't consider. One was they didn't necessarily take into account, I think, the supply and demand components here, where we were also subsidizing way more healthcare insurance than we had before. People were receiving much more healthcare, and so they started restricting the supply, or advocating for restricting the supply of incoming doctors at a time when demand was exploding for care. So the fears were definitely unfounded. Obviously, hindsight's 2020, but it wasn't grounded in economic principles. It was grounded in the idea that too many doctors would reduce the quality of care, and we didn't see that. Now, there's a few things that happened during that time as a result of this. Not everything can necessarily be traced back. I don't want to make Gemini the ultimate arbiter of why we have a physician shortage.
I just think it's an interesting thing that we just get stuff wrong like this.
Yeah, it's 100% a driver of why we started doing things. Well, number one thing that happened under this period was a recommendation to medical schools to freeze MD slots. So in 1980, medical schools agreed to freeze MD slots. Now, if you look at a chart, obviously we're on podcast, I can't show it to you, but if you look at a chart and
it's a very visual podcast. Yeah.
Yes, right. If you look at a chart and kind of the production of MD matriculants over the course of time, you see a drop in 1980, and once that moratorium was lifted in 2002, you can see us sort of catching up, and we're still trying to catch up due to residency is obviously what I would call the primary bottleneck, but you can't overlook shutting down the building of new medical schools and the creation of medical MD slots as a result of these concerns in 1980. Another thing we did in 1997 was obviously cap the amount of money or cap the amount of slots that Medicare funds for residencies. Now,
and Medicare is the bulk of funding for residency slots.
Medicare is over 80% of funding. Medicaid covers 15%-ish. And then there's also DOD, Veterans Affairs that cover small portions of this. But yeah, so when we did that, we essentially not just capped the cap is on the funding. It's not on the doctors we're producing. I think this is an important distinction. I think some people will mix this up. They'll say we capped doctors. Hospitals are allowed to create residency programs as often as they want. They can build schools. They're not necessarily, there's all kinds of restrictions, but there's not necessarily a cap on the amount of doctors we can produce. But we did essentially tell hospitals that if you want to create more slots, we're no longer going to fund them. We're only going to fund the ones that you currently have. But we did not necessarily see private or Medicaid funding step in to fill this gap. I think you're seeing more of that over the last 10 years than you did previously. But our shortage every year, over 3,000 folks who graduated medical school and want and applied to get matched to a residency do not get matched because we don't have enough slots. That shortage can be directly attributed to several constraints down the line. Medicare capping this funding is just one of those constraints.
All right, so let's talk some numbers here because I think we started getting into, well, what can we do about it? It's crazy. So the 97 Balanced Budget Act capped the number of residencies that we're funding at 1996 levels. There's been a recent increase of what, 1,000 a year, or so. Yeah, 1,000 a year. It's between 20 and 25 billion dollars. You said Medicare does about 80% of it. We're talking 15 billion or so. Medicaid kicks in another 5 to 6 billion. More on the state side, I want to say. Veterans Affairs, 2 billion. There's Children's Hospital, GME. All right, we're talking about 36,000 or so residency slots a year. The math there, if you just divide and divide, you get $180,000 a year per resident. And again, residents are going through for 3 to 9 years or so. And so I think that helps us start to think about, if the government were to spend money to try and increase this, how much would it cost? $180,000 a year per resident. It's a few billion for a few more thousand doctors a year. I mean, is it as simple as that?
Unfortunately, no. I wish it were as simple as that, because there's sort of, I'd say, so let's step back and think about shortage. The first thing that's important to note is the term shortage is not a term of science; it's a term of art. We don't exactly know what a shortage means when it comes to healthcare. We know we can create sort of numbers for demand and supply for healthcare, but this is not a precise measurement. What we can know is sort of like, what do we expect? What is the standard for the amount of doctors we want per capita, and where are we lacking in that? And I think that's fair. But the best measures we have are that we're going to have a shortage of anywhere from 30,000 to even 130,000 doctors over the next 10 to 20 years. Knowing that, you would think you just pump 10 billion into this Medicare funding, you're going to have people build more teaching hospitals, you're going to have more slots created, everything will be okay. But the shortages are not nationwide distributed perfectly. The shortages are both by specialty and by region. So, for example, if you look at a map of the United States, there's some helpful research done recently that sort of gave a score to each state based on its shortage. And they gave a score now and a score for 2040. And the only states that were a C or higher on this score were in the Northeast. The Northeast was the only region that projected to not actually have a technical shortage than in other states. And it's not a coincidence that that's where all of the residency programs are located. And so you have a geographic distribution shortage that is precipitated and that is helped on by the way we fund the residency programs. Because Medicare funds its payments based on the amount of care that's being received. When when most of these residency programs are located, these teaching hospitals are located in the Northeast, that's where the money is going to go as well. And so New York will get almost double the amount of money per resident than Georgia gets. And so
are these numbers like updated for like population changes, like where the money ends up going at all, or it's just purely the slots have always been there, so they're there in the future?
Great question. So the direct payments, the DME, so GME is direct and indirect, DME and IME. The DME payments are still based on hospital cost estimates from 1983. Those have not been adjusted.
So that's probably one thing to look at again.
That is one thing to modernize. And then IME is still based on just the bed to resident ratio or the bed to intern ratio. And that obviously changes every year. But I don't necessarily know if they're keeping up with that in a way that makes sense. I do know that sort of geographic disparity persists in the way we fund. Because when we capped the funding levels in 1997, we inadvertently also capped the geographic distribution of funding, which I think is maybe even a more important element of capping the funding than just the actual raw number is, because we sort of made it even more inflexible than it was previously. Obviously, if the funding continues, then you can incentivize southern states, teaching hospitals in rural areas to maybe. But when there's no guarantee that any more money is coming, then there's nothing you can do about that. So I'm sort of a little bit off track from your original question, but it's important to go back.
What are like sort of the alternative ways that we could fill residency slots if we don't want the federal government spending it? Is there like, hey, you're a resident, you're going to pay this hospital for the next 20 years for the training we're going to give you, and you're going to give us 5% of your income?
So Arkansas is doing something interesting where they're sort of created their own state Medicaid-funded grant that just goes directly to teaching hospitals. I think more states need to consider taking matters into their own hands. Our report that we put out, my colleague Robert Orr, who used to work at Niskanen Center, he put out a great report called Unmatched, and that recommended sort of a consolidation of the funding streams. And so this would essentially create a uniform per resident rate that that won't be as affected by the geographic distribution of slots. It's just per resident. It's not based on how much care you're offering or how expensive that care is. It's just based on how many residents you have. That having Medicare just do a per resident uniform amount, and then making the Medicaid dollars that they use for GME, which is also, it's important to know, the Medicaid dollars are also based on reimbursements for inpatient and outpatient care. So the way Medicaid is also hamstrung by their ability, how expensive the care is that they're offering. So these teaching hospitals, like so many situations in the way government funds healthcare, have strong incentive to do higher, more expensive services. Important note here, primary care services are not as expensive as services done by those with higher or with more advanced subspecialties. So it's also an incentive for hospitals to not create primary care slots, because those residents are going to bill for lower rates than residents that have higher subspecialties. That's one of the reasons subspecialties have exploded around the same time we start funding these slots. Yeah, so that's and then making those Medicaid portion flexible, so that states can, rather than it being on a reimbursement basis, funding Medicaid GME programs on a flexible basis, where the state can decide, oh, what teaching hospitals, what areas of the state need these residents, makes a lot more sense.
So give me a sanity check here, because I also read Robert Orr's paper because I went through your footnotes, and Unmatched. It's a good one, and the suggestion is just make it per resident, uniform payment. And if you did that, it's not that every teaching hospital, the cost of covering that, of putting that resident in there is the same. And in fact, in low cost areas, you could bring in more residents. I mean, it's like trying to build affordable housing in downtown San Francisco. What are you doing? We have the whole interior of California, which is much lower cost. Do it there. You can build so much more housing. And so could we actually spend this, if we readjusted this, could we spend the same amount and get more residency slots if we did this per uniform, or, uniform per resident slot, and eventually over time distributed to, hey, low cost states with teaching hospitals, you can now get many more residents?
It's a great question, and I think it's probably an overlooked aspect of GME reform. Obviously, our recommendations for GME reform is, of course, to eliminate the cap, or at least increase it, and somehow incentivize more slots for primary care. Obviously, I think that makes a lot of sense. But I think, like you said, an underlooked aspect of this is the way we fund it doesn't make any sense. And spending $180,000 per resident, that doesn't make sense either. So I think the numbers bear that out. That if you were to create a uniform per resident amount, that you would be able to create more doctors. Obviously, there's separate from all of this. There's obviously a sort of a separate question that I think is probably more intractable, which is the motivations doctors themselves actually have in what specialties they want to go into. Because I think it's important to note that we don't necessarily have a shortage of specialists in America. We do have some regional distribution problems of specialists, but those are unique to areas and need to be attacked on a case-by-case basis. The primary care shortage is not unique to areas, does not need to be attacked on a case-by-case basis. Every county in the country has a primary care shortage issue. So making sure that these slots are going to primary care doctors is far more important than making sure we increase the slots. I think that's a critical sort of priority setting that needs to be done.
If we're still trying to increase the number of physicians in America, I have to ask about international medical schools. This shortage of, okay, we've graduated people from medical school and then there aren't enough slots for them. Is that partially because we've got international graduates who are required, even if they're board certified in, pick NHS Canada, Germany, whatever, they need to come and do a residency in America again in order to be licensed?
Yeah, it is. So if you just do the numbers, don't think about distributions, don't think about regions. We have enough currently under or unemployed international medical graduates to fill our physician shortage. We do. We have over 100,000 based on Migration Policy Institute's estimates. I personally we're working on a report at Niskanen with our immigration team that will come out at the beginning of the year that provides recommendations to states on how they can help waive residency requirements and other barriers that immigrant doctors have to becoming doctors in the U.S.
Wait, really quickly, you can wait. So it's a state decision, not a federal licensing one. I mean, does it work like law school, where you got to pass the bar in each state in order to practice there?
Yeah, that's a helpful comp. So it's essentially every state has their own licensing rules, but there's only legislation has been passed in 4 states that allow an international medical graduate who got a degree, say, let's just use, I've been talking to IMGs in process of this report. I've been talking to one who did general surgery in Egypt for many, many years, came to the US because her husband was moving here, immigrated here, and now has been doing medical coding, driving Uber to make ends meet, because there wasn't a single, there's a couple things. One, and she moved to Washington State. The state of Washington does not allow you to just like pretty much 48 other states doesn't allow international medical graduate to practice without repeating their residency. Now, as we've talked about, residency is the primary bottleneck. So a very difficult process to get a residency slot, particularly as an international graduate who is less competitive than even domestically trained graduates. In addition, many medical schools require you to be only so many years removed from your initial MD degree graduation date. So she was more than 7 years removed, obviously, because I think she's in her 40s or 50s, more than 7 years removed from her original MD graduation, even though she's been practicing general surgery for over 20 years.
That doesn't make any sense.
It doesn't make any sense. And so there wasn't a residency in her. She had to apply to residencies in like thousands of miles away because most of the schools wouldn't even let her apply. So lots of barriers that IMGs face. There's also the licensing boards. There's the hospitals themselves that don't want to take on the risk. They worry about risks of hiring an immigrant doctor, and most of the I think concerns are nonsensical. But the bottom line is we require these doctors who have sufficient training to essentially duplicate their training here in the U.S.
Do you know if an immigrant doctor gets certified in a state and that state is part of the Interstate Medical Compact licensure? I can't remember what the final one there is. Are they then good to move around and easily transition to another state?
Yeah, so it's a really interesting thing. So, like for example, Tennessee passed the law that says that IMGs, international medical graduates, do not have to repeat their residency. So, essentially, the issue though is that it creates an alternative pathway. It doesn't put IMGs on the pathway that U.S. trained physicians on. It creates an alternative one. And so when you do that, you also have to build the infrastructure around that pathway to smooth the process. And so, for example, a Tennessee IMG who now no longer has to worry about duplicating the residency requirement still has to get licensed. And so they still have to deal with the licensing boards. Now, individual licensing boards on the subspecialty basis still require you to have a US-based residency. So even if you waive residency requirements, there's also going to be a specialty by specialty issue with licensing boards. Now, if you can get past the specialty boards, if you can manage to either convince them to change that requirement, build the infrastructure around that so they can bill under their insurance. There's so many building requirements. So to answer the question, yes, technically speaking, then the state would license you. And if you have a portable contract, but then you'd still have to deal with other barriers those other states in that compact would have.
I mean, maybe that leads to more primary care physicians instead of specialists, even if they were specialists in their foreign country.
Well, I think there's a reason why more IMGs go to primary care than US domestically trained doctors. It's a little bit easier.
I'm just curious, as far as outcomes are concerned, when you do see these liberalizations, is there any evidence at all that there are quality questions or, anything on that front?
Yeah, no, it's a fair question. I mean, I think so in terms of just the quality of care that immigrant doctors provide versus domestically trained doctors provide, the research is pretty much settled in that if there's any lean, it's actually towards the immigrant doctors in terms of higher quality. Not the other way around. I think you also, in a country like the US that is increasingly more and more diverse, it only makes sense that our doctors would be so as well. And so I think we're selling ourselves short by creating these sort of artificial barriers, particularly when you have a lot of immigrants moving to rural parts of the country, seeking opportunity. It's the American dream. And yet we don't let doctors who are probably part of that immigrant population practice in those places to care for those people who are moving there. It's a non-starter of a position from the position of like the specialty boards, the licensing boards, to try to prevent immigrant doctors. The AMA in Tennessee came out against waiving these residency requirements, kind of using the traditional anti-immigration rhetoric over concerns about salaries and quality, and there's none of that is based on evidence.
Yeah. I mean, we've done, when you look at whether it's scope of practice rules for nurse practitioners and things like that, right? Like time and time again, the AMA is like, oh, this is going to reduce quality, and then time and time again, you're like, the studies do not suggest that at all, and
Yeah. Scope of practice is a good a good example of that too. I think it is important in these sort of big healthcare things that you do have to think through the incentive structures. Like I read recently a report from the Cut about how nurse practitioners, when they're given more authority, ended up doing more lip fillers and going to like plastic surgery places. And it's one of those situations where it's like, oh yeah, like there's another perverse incentive I didn't even think about in healthcare. So I think it's
That is filling an important need.
sure.
That is like the one space where people pay out of pocket for it too.
No,
It's not even
it's a
covered
good.
by insurance, right?
No, totally.
This is like the one example where the market is revealing what people's preferences are.
Right,
Not
exactly.
my preferences, but yeah.
Sure, yeah. No, so there's all kinds of like, I don't know, in healthcare, I am pro being very considered. I'm pro being very like thinking through the potential impacts of these sweeping deregulatory decisions.
So
But
how did Tennessee go about overriding, looking the other way when AMA came a knocking?
yeah, it's a
What
good
did,
question. I actually I don't know that I have a good answer. I know
mhm.
that they so AMA like the if you go to their website, there's nothing about opposing. I think obviously it's a bad look to be opposing
Mhm.
making it easier
Yeah.
for immigrant doctors to make a living in the United States. And so I don't know that there's necessarily going to be official statements from the AMA on something like this. And so as a result, I think you had the state level AMA talk about opposing it after the bill passed. I don't know how much work they actually did um, in terms of lobbying efforts to actually prevent it. They obviously weren't successful. I'm very, very hopeful. Obviously, we're working on a report. I'm very, very hopeful that this next year is a huge year for that type of reform at the state level. I expect it to be just based on the workforce challenges that these states are individually experiencing. When Illinois and Tennessee both do the same, essentially the same reform, I think that's sort of a clue to other states that this is something that can be done on a bipartisan basis. Um, so I'm hopeful that we'll see that. But obviously, just waiving residency requirements will only be so helpful. There has to be infrastructure building along all parts of the pathway for IMGs to actually practice medicine in these states.
All right, Lawson, this is very helpful. We now know who to blame if the residency system isn't fixed within a year or two. We're leaving that up to you. Yeah.
Well, great to talk to you guys. Thank you so much for having me on.
Lawson, thanks.
All right, that was Lawson Mansell of the Niskanen Center. It was a lot of fun, Danny. I
He's
think
going to make us look good, so that was nice. Yeah.
that's
So,
what we
yeah.
really appreciate. All right, moving on. We have one listener feedback. I'm going to read from Patrick Sierra. I'll read you the whole thing, Danny. I think this is really a question for you. Here we go. I've
No,
been
it's for
in.
both of us.
Oh
It's
yeah.
yeah. You have
Okay.
the answer too. Yeah.
All right. He says, I've been enjoying the podcast and have one point of inquiry regarding the healthcare prices episode. I agree with essentially everything presented, discussed. That's great. But, not everything. But am left with
Thank you for
one.
your feedback. That is sufficient.
Yeah. But am left with one open question concern that all of the arguments around we shouldn't bargain drug prices down because it would reduce innovation prove too much or have no limiting principle. More or less, why not pay $24,000 a year or $100,000 per patient for something like Wegovy, the semaglutide, rather than just the $12,000 current list price? Why not do that? Would that generate even more innovation? Prices need some anchoring mechanism. We need to decide on some finite amount of additional subsidization above whatever a hypothetical market mechanism would be that we want to do for drug discovery. I'm really interested in the conservative rejoinder to how much should we subsidize innovation in pharma framing? So, Danny, this is the opposite. We were saying, well, you don't want to bargain drug prices down too much, was what we were talking about, because it stifles innovation. So, on the flip side, doesn't that mean we should just pay more because it will increase innovation?
This is why I was opposed to doing listener feedback, because you'd get like a good question that would
Uh-huh.
make it.
It is a good question.
You would need a nuanced answer, and nuance is not good for things like this. Yeah, I've struggled with this issue because I even when the Inflation Reduction Act first came out, and it was there's all of a sudden going to be many fewer molecules being made because we're reducing the price. I'm just like, well, wait, like if Part D is the reason why we're people are innovating, then the government's already subsidizing it. And like as the free market guy, I'm like, oh, that's a distortion, right? The subsidy creates this distortion. And so then the flip side of it is, well, like if the government is just taking away that subsidy in some way, then aren't we, we're just resolving that distortion. And I part of me still kind of leans that way to some extent that, maybe if you were to just say, is Part B worth all the producing all these extra drugs because it's saving so many lives? And you're like, yeah, I think it is, but It's actually a really tough question. And so I would say, first of all, in the case of the Inflation Reduction Act, it's not hard to say that what they're doing, the way they went about trying to reduce the amount of money that the federal government spends on drug prices is bad. The Inflation Reduction Act's prescription drug price negotiation program comes with really strange rules that distort the incentives of what kind of drugs to make, when to release them. That if you're familiar with the program, you have 9 years before a drug gets regulated. And then at that point, the federal government comes in and says, we're going to push the price of your drug down to some lower negotiated level. But that negotiation is if you don't come to terms with us, you have to stop selling this drug to everyone on Part D. And if anyone buys your drug on Part D, there's huge penalties. And if you don't really come to terms with us, we're probably going to tax you a lot. And we're going to tax you. The penalty can be as much as like 100% of your gross revenue on all of your drugs that you sell in the US. So it's a very big penalty. And so you could say, well, like right away, this isn't just a small, this isn't just playing hardball with the drug companies and saying we're not going to fund this drug. It really is, we're going to put you out of business if you don't come to terms with us. And so obviously that's a different kind of take. And beyond that, there's just this, because there's 9 years before your drug gets priced or before your drug gets regulated, it distorts incentives on, okay, well, what do I charge initially to make sure that when my drug gets negotiated, that I'm beginning with a high price that CMS may, give me a higher price in the long run. Or maybe I wait to roll out my drugs because ultimately most drugs, the first couple of years after they're released, the markets are really small. So let me hold off. Let me maybe see if I can get a second or third indication on my drug before I roll it out to the public, all to prevent the clock from starting. And those are bad incentives that we don't have right now, where right now you invent a molecule, you have an incentive to get that drug out as quickly as you can because your patent life is ticking. And so you want to get that drug to market as quickly as you can, where now the incentives change. So I think putting that aside, more generally, I think it's a hard question to answer. And I think I'm really skeptical because the left does this often with a lot of their policies. They have a study that says the child tax credit will, improve the future finances of children, and so therefore we need to spend more on the child tax credit. And they say the things about SNAP and all of the other programs that they happen to like. And I think you can make this sort of the same case here, that we can prove too much. We can say, well, this drug will save $200 billion in life years saved, and therefore we should be throwing more money at it because it's going to increase innovation in some respect on the margin. And ultimately, the federal government faces budget constraints, and I think that's probably the best answer. Is we can't spend money on everything, and we should be deliberate in how we spend it. And if the government's causing economic distortions, that's probably a bad sign. But it's not a great answer, I'll candidly admit, and it's a tough question to answer.
You know what? I'm not even going to weigh in. I like your answer. I'm good with that. All right. If you have more feedback, send it to us. Feedback at 584vetos.com, or find me on Twitter, at Tom V Church. We'll end with our veto of the week. Danny, unbelievably, the next one in line, April 26th, 1887. Grover Cleveland vetoes an act for the promotion of anatomical sciences and to prevent the desecration of graves. The bill's aim was the bill tried to allow the delivery of unclaimed or pauper dead bodies to medical colleges in D.C. for dissection and anatomical study. Can't believe that it's a medical veto. Grover Cleveland objected because while these bodies were being delivered to medical colleges, the surgeons and physicians who the bodies were delivered to would have to put up a bond. So every physician or surgeon, before receiving such dead body, would have to put up a bond. And he thought, this doesn't make sense. We're requiring physicians to do something when administratively it probably makes sense, since they're delivered to the medical college, to have them handle it. This is just, I think, goes in line with the standards, the requirements that we put on medical colleges, on physicians. It's not a nice one-to-one comparison, but it is a medical veto from Grover Cleveland.
And pure coincidence that it just happened to be this week. We are going in order on vetoes. I guess the question is, like, what was happening? Like, they would do something with the cadaver, right? They would do some experiment or whatever.
The
And then
second half of this was making sure that if the family of the body of the family of the the deceased body wasn't happy that it wasn't being buried, wasn't being taken care of, is to prevent the desecration of bodies.
So it really was like doctors were like, well, I got the liver out of this one, so let's just throw it on the curb or in the alleyway and not my problem anymore.
I think the late 1800s
That's
were a tough time, Danny. All right, thank God for standards. Thank God for vetoes. We'll talk to you soon, closing out episode 584 vetoes. Talk to you next time.
bye.
The views and opinions expressed on 584 vetoes are those of the authors at a particular moment in time and do not necessarily represent the views or opinions of their employers or their future selves.